Features of Liddle Syndrome. This is an autosomal dominant monogenic condition that is caused by mutations to the epithelial sodium channel, which is responsible for the Na plus reabsorption in epithelial cells. The study encountered 12 cases of Liddle syndrome and its present symptoms on each patient. Cases of it are rare, with the study having the largest known gathered sample size of patients in the research of this condition.
Common symptoms of Liddle syndrome are early onset salt-sensitive hypertension. This type of hypertension occurs early among individuals afflicted with Liddle syndrome and is characterized by increases in blood pressure because of salt intake. In the case of Liddle syndrome, however, hypertension is caused because of the hyperactivity of the epithelial sodium channels, which causes the body to retain more water and salt than usual. Another significant symptom is hypokalemia, or otherwise simplified into a deficiency of potassium in the bloodstream, thus resulting in low blood potassium levels. This is primarily caused by the hyperactivity of the NAC channel. As it functions, it filters out the potassium in the kidney and retains salt and water, thus causing salt-sensitive hypertension and hypokalemia. Metabolic alkalosis also occurs in patients that are afflicted with Liddle syndrome, causing an imbalance in the body pH that makes it more alkaline than normal. Liddle syndrome is an autosomal dominant form of hypertension, which means that the disease is inherited if one of two parents possess such disorder. It is caused by gain-of-function mutations in the epithelial sodium channel, or medically abbreviated as NAC. This channel is specifically responsible for the reabsorption of sodium in epithelial cells and are composed of three subunits: the alpha, beta, and the gamma NAC. In the case of Liddle syndrome, missense, nonsense, and frameshift mutations in the C-terminal ends of the beta and gamma subunits, along with the mutations of the proteins that encode the NAC channel, SCNN1A, SCNN1B, and NCNN1G, lead to problems involved with the channel, causing it to increase in activity and put strain in the kidney as it forces the organ to retain more water and salt than needed. Liddle syndrome is mostly hereditary and is a very rare genetic disorder. Its autosomal dominant hereditary pattern means that it is not restricted to male or females, that a singular copy of the gene is only needed in order for the disorder to manifest completely.
According to the report in the article, genetic analysis plays a crucial role in diagnosing Liddle syndrome. Researchers were able to identify a mutation in the epithelial sodium channel, or what we call ENaC, in all 12 patients included in the study. It says that spironolactone is not an effective treatment for Liddle syndrome because it fails to target the specific mechanism causing the disease. In the patient Liddle syndrome, the problem lies in the malfunctioning of epithelial sodium channel, which are unable to bind to protein ligase. On the other hand, tiamtilene, a potassium spirin diuretic, effectively treats the Liddle syndrome by directly blocking the sodium channels and preventing further reabsorption of sodium.
For medication, all patients receive regular doses in a day, but one is only limited to a few patients and another was not continued as it has resulted in unpleasant results to their health. In the study, medication done were 3 doses of potassium supplements ranging from 80 to 120 millimoles to regulate potassium levels, antihypertensive drugs with no ENaC blockers on attempting to control their BP level, 3 doses of spironolactone on 60 milligrams, although only limited to a few individuals, and 3 doses of trimetry ranging from 50 to 100 milligrams per dose. but it was halted to a handful of individuals after the adverse readings or reactions recorded in the body of the patient.